Good morning and good afternoon. Welcome to Telehealth Opportunities Explored, a complimentary webinar from HealthSystemCIO.com. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com, and I'll be your moderator today. We certainly encourage the asking of questions. I think this is a great topic for it. So when they occur to you, feel free to type them into the Q&A box in the lower right-hand corner of your screen. Leave the default set to all panelists. We'll field them later in the program, but as I mentioned, send them in at any time. Download the deck if you didn't do so already. There's the URL there, and we also have a shortened URL at the bottom of all slides. We'll also send it out in the chat box during the event. And we are recording today's event, so you will have an archive available usually within 2 business days. You'll get an email when it's ready, and a separate registration is required. So you see how we're going to spend our time today. First, we're going to hear from our good friend, Dr. Daniel Nigrin, SVP of IS and CIO at Boston Children's Hospital, and then we'll do our Q&A with Dr. Nigrin. So without further delay, I'm going to turn it over to our special guest. Dr. Nigrin?
Hi, everyone. How is things going for folks today? Oh, I guess you can't speak yet, so I hope it's going well. How about that? So thank you for having me, Anthony. It's a privilege to be speaking today and hosting this webinar. I am talking about telehealth today, and it's a domain that we've gotten into over the last several years and had really a lot of positive experience with. And so we wanted to share a little bit of our experience with folks today. Telehealth, as we think about it here at Boston Children's, is simply removing the barriers of time and distance as we care for our patients. We do this in a variety of different ways. We use live video. We use store and forward technologies. We do some work with remote patient monitoring. And, these things are changing over time as well. As technology progresses, we're trying to keep up with new advances. But these 3 types of telehealth approaches are now pretty well established, and the technology is sufficiently robust that we've been having some good success with these. Now, I think if you're on this call, you likely don't need much convincing that telehealth is something that's an approach that really holds great promise moving forward. Certainly, it's convenient for our families and patients. It allows them to have access to their clinicians easily without having to travel to their providers. It allows for a potentially greater number of contacts with those providers. And ultimately, we hope that this is going to be a tool that will allow us to provide higher quality care to our patients. There's also a promise that this could be a way that we could reduce cost of care. Certainly, being able to have a patient do a telehealth consultation that might prevent them from needing to make a visit to an office or to an ED. Avoiding rehospitalizations, taking care of something post-discharge through a telehealth consultation that might avoid them having to get readmitted to the hospital. And in general, reducing the total cost of medical expenditures and bending that cost curve. We really do feel strongly that telehealth is one way to do that. We'll talk a little bit later about the payment methodologies and how that figures large in that equation, though. So thinking about telehealth, obviously the conversation generally goes to technology, but I think it's very important that we think about telehealth as not just technology. It's a partnership, really. And there's certainly technologies and staff that are centered around those technologies that are critical. And so this is traditionally your telehealth program office, and those are the folks who are helping with the technologies, facilitating things like legal discussions and introducing clinical folks to the tools and how to use them. But clearly you need clinical engagement and clinical involvement. And without that partnership, I think telehealth programs are generally not successful. You need both parts of that equation. So as we think about telehealth at Boston Children's, we've been thinking about it using this right care at the right place and right time model. And so the first way in which we've been doing this is by providing telehealth support to community hospitals. We've got several programs already set up, some of them in pilot mode, others in full production mode, where we allow our clinical experts here at Boston Children's to deliver advice and care to remote providers at community hospitals. So some of the ways in which we've done this are around critical care support, so community-based pediatric emergency departments who sometimes need additional help in managing patients. In some instances, it might be in stabilizing a patient before that patient needs transport to our facility. They actually engage with our clinicians using a video consult system. There's a fantastic example of this in action that we recently had here at Boston Children's, where a child who had aspirated a chocolate-covered pretzel out in the community and was really not in a good way and was having essentially imminent respiratory collapse, presented to the remote community hospital. And they obviously attended to the patient right away and stabilized them, but his condition was deteriorating rapidly, and they needed that expert advice on how to manage ventilator settings and this particular scenario. And so the telehealth consultation happened, and that child was stabilized, eventually transported to our facility, ended up on ECMO, and the great story end is that the child did fine. But that could have gone a very different direction had the video consultation system not been in place. We've got a variety of other approaches as well. We do teleconsults for different subspecialties, inclusive of, as you can see, remote retinopathy of prematurity screening. So our pediatric ophthalmologist do remote visualization of newborn infants' fundi to see if they've got retinopathy of prematurity. We have several other subspecialties that are doing scheduled and real-time synchronous consultations at community hospitals. We also do what a variety of other facilities do regarding teleradiology, doing remote reads of radiographic images. And similarly, we have our neurologists and cardiologists do remote reads of EEGs and echocardiograms for those facilities that might not have pediatric subspecialists in those particular specialties. We are also working with our patients directly in their own homes. And, some examples of this include our OWL program, which stands for Optimal Weight for Life program, where we're doing in-home visits for children being followed with obesity. At the very other end of the spectrum, we've got a program which we call CAPE, which is for technology-dependent kids who are on home ventilators, for example. In many instances in the past, those kids needed to come into the hospital for management and periodic checks to see how they were doing. And you can imagine a child who's on a home ventilator with other technology dependencies. That trip to an office for an ambulatory visit is no cakewalk. So being able to do a remote visit with experts on the other end of a video hookup, where they can visualize the child's technology settings, they can visualize the child themselves, that's a real game changer for these kids to be able to have that care delivered at home. We do several other types of visits in the patient's home, including diabetes follow-up visits, concussion follow-ups, which is obviously top of mind for many families these days, plastic surgery, post-operative care. We're doing those remotely. And then we've got children who are on chronic parenteral nutrition who also have follow-up done via telehealth systems. Now, what are some of the barriers that are in the way of even further deployments of these kinds of technologies? There's for sure the state licensure issue, essentially that the practice of medicine is defined where the patient is, not where the provider is. So unless you're licensed in every state in the nation, which is obviously not a tenable scenario, you are going to be limited as a physician regarding what care you can deliver remotely. So this is a significant issue that needs, frankly, to get addressed at the national and state level. But even within states, there's issues around hospital privileging. For example, in Massachusetts, we require primary source verification for each institution to be able to verify the clinician's credentials before they are credentialed for that organization. So for all of those hospital-to-hospital programs that I mentioned before, that required us to credential each of those physicians that's going to deliver care to those remote hospitals to be credentialed primarily in those organizations. Now, to anyone who's ever done any physician credentialing, that's no small task, and so this is a significant burden. There are some other forward-thinking states that have managed to put into place credentialing by proxy, which allows one organization to proxy their credentialing to the other, and that certainly would streamline things. And so if you live in one of those states, you're lucky. We unfortunately are still battling that one here in Massachusetts. And then finally, there's the reimbursement issue that I mentioned before. Although Medicare does reimburse under some conditions, as a pediatric facility, we're obviously not a big part of that program. And on the Medicaid side, where we do have a big footprint, we are not reimbursed at all in the state of Massachusetts. Furthermore, on the commercial side, there are some commercial payers that are requiring that are paying for these services, but it's not uniform by any mean. And so this lack of uniformity across the payers makes it very difficult to implement some of these telehealth programs. You can't expect a clinician to determine on a case-by-case basis whether to issue a charge or not by looking to see what insurance they have. So this is a big burden which we hope will get solved from a regulatory perspective. Now, the ROI that telehealth can deliver is certainly top of mind, and as I said up front, intuitively we all think that there should be an ROI here. But this is an instance in which the payment methodologies that we currently live under are not necessarily in sync with the practice that we want to provide. So only currently around 5 or perhaps 10% of our patient population is now in a risk-based arrangement for payment. So that means that the vast majority of our patients are still in fee-for-service agreements. Although I do see this as changing over the next several years, the bottom line is that right now, if we manage to substitute a virtual visit for an in-person visit rather, that means directly a decrease in physician revenue, and in some instances a decrease in hospital revenue if we avoid hospitalization. So clearly the incentives are not appropriately set still. We think that the risk-based arrangements that are coming with various ISCIO initiatives and pay for performance and pay for quality efforts, all of those things are going to help for telehealth. But as I said, we're not quite there yet. That said, we have taken some stabs at trying to estimate how much these programs are potentially reducing the overall cost of care. So as an example, I bring the CAPE program, the TeleCAPE program, back up. And this shows you how with just 27 video visits covering just 14 patients, we estimated close to $100,000 of savings for that very small subset of visits. Now, clearly, there's a lot of assumptions that we've made here, but we don't think that these assumptions are that they're stretches in any way. Just the avoidance of a single ICU admission, which I can tell you for any one of these children who need to come to the hospital and be admitted because of their technology dependencies, it's an automatic ICU admission. So that one single admission at $83,000, that's a big cost saver. So even if you prevent one of those using these technologies, you have the ability to potentially reduce the overall cost of care for that patient in a big way. We're also thinking about applications of telehealth in areas where we can currently manage to reduce the overall cost of care without a change in our revenue stream. And for us, that's primarily in our post-operative and post-discharge phases of care. So for post-surgical patients, for example, where we receive a global physician payment, if we can see a child and deliver the same quality of care for a post-operative follow-up visit using a virtual visit as opposed to an inpatient visit, we certainly will take advantage of that, because there won't be any change at all in the revenue stream that we see or that the physicians see. But certainly it can make things more convenient for the clinician, certainly makes them more convenient for the patient, and I think that's a win-win all around. So this is an area where we're really pushing quite hard at this point. I already mentioned the plastic surgery post-discharge and post-operative care that we're doing. But really the real ROI, we feel, although all of the financial things are obviously important, the real ROI comes with the benefits to the patient. The times that we've used telehealth in all of the programs that I've described, I cannot stress the number of times that we've gotten positive feedback from families regarding how thankful they were for doing this, because they do feel as though they're getting the same quality care, and the convenience that it provides for those families is really something that's hard to measure. Not to mention that there is a financial benefit for the patients too, not having to park at the hospital, using gas, taking time off from work and school. All of those things add up quite a bit for our families. So what are some overall top-level lessons that we've experienced here at Children's around being successful? The first is something I've mentioned before, and that's identifying clinical champions. You really do need a clinician. It doesn't need to be a doctor, although that's most often the case, but certainly we've had lots of nursing involvement, respiratory therapist involvement, and all of those folks as well can be champions and should be champions of these efforts. But having that clinical involvement is really key. Because they can give you important feedback on what's working and what's not working, but most importantly, they've got the ability to enlist their peers in believing that this kind of approach is one that's got legs and is going to be beneficial to them and to their patients. It's also quite helpful when you're negotiating for resources with senior leadership to have clinicians on board and behind these kinds of programs. The next lesson, rather, is on focusing on the need. You don't want to implement programs that really no one's asking for. So in many instances in which we've piloted and then proceeded with telehealth programs in a production way, those have often been led by folks who've come to us to say, hey, we've got an idea for visits that we might potentially be able to do remotely. Can you help us do those? When you've got that burning platform and compelling need expressed by a clinician, those are the kinds of opportunities that you need to seize and take advantage of. Because when you're successful in those areas, those folks will then become your clinical champions that will tell their peers. The third lesson is around putting the families and the patients really at the center of this. The primary goal of the deployment of these systems is in trying to meet their needs first and foremost, making the technologies be easily accessible to them, easy to use, and not necessarily having folks think that just because they're doing a video visit or a technology-enabled visit that they're not getting the same level of support and care that they would have in person. And if you work hard at this, and we have been, we've had the experience that our patients are actually quite convinced of the fact that they are receiving that same quality care and that the technology didn't depersonalize or diminish the visit in any way. Resources are always important, and none of this is possible unless you've got the right technology systems in place, the right financial backing, the right human resources, including the clinical resources that I've mentioned before, and good communication across your organization. Seeing patients in this way is a big change for clinicians, let's face it, but being able to communicate what's coming and what those changes are is incredibly important. And then finally, although I tend to try and diminish the technology aspect as much as I can when talking about telehealth, the technology is important, let's face it. So choosing the technologies wisely, including the obvious things, around the video quality, the type of end user devices, the branding, what kind of mobile and peripheral devices your clinicians and or your patients might be using. Clearly, all of those are important. But many systems out there also offer additional features and functionality that may not be intuitive out of the gate. So do pay attention to these things in the right-hand column because they are potentially available to you in some vendor-based systems. So just to wrap things up, I think the strategies that you've got to deploy and implement when implementing a telehealth program. Clearly, patient privacy is always an important aspect. You can't skimp on the security, and you need to be sure that the security is in place to a sufficient degree to give comfort. We don't want our users using relatively insecure technologies simply out of convenience, so things like Skype, FaceTime, etc. Although they certainly are convenient, we need to hold ourselves to a higher standard regarding around the security. And so our goal is to then deploy things that are secure and yet as easy to use as all of those commodity kinds of systems. Implementing technology that is in the workflow of our clinicians and is easy to use and fits their workflow as well for our families. Both of those things are obviously critical. Another aspect is to not consider failure and challenges something unusual. You will hit them, absolutely. We certainly have, and use them as learning experiences and iterate often. And as you iterate, you'll find yourself getting closer and closer to a really streamlined and great system. You have to go gradually with this. This is not something that you can big bang across an organization, but we are disrupting things. This is a new approach to patient care, and so there are times where you need to be a little bit disruptive. You need to challenge that status quo, and so sometimes you do need to be bold. But we've learned a lot from our initial pilots, and I would advise that approach generally before going large across your organization. Along those lines, just thinking ahead as you invest in technologies, don't think about them specifically for just your pilots. Think about, okay, if these pilots are successful, how might these systems ramp up across our whole enterprise? And obviously promote your successes. These are new technologies, and people need to hear about these wins and what our experience has been, so that they can have confidence in them and are ready to jump on board as well. So finally, I just would like to thank the folks on our team here at Children's who are involved in all of our telehealth efforts. essentially none of what I've just described is my own doing, and really all of the doing of the folks on this screen. So thank you to all of them. So with that, Anthony, I think we're ready for questions.
Very good. Excellent, excellent. Wonderful presentation, Daniel. Okay, so we've got plenty of time for questions, so go ahead and send them in, lower right-hand corner of the screen in the Q&A box. Leave the default to all panelists, and we will pose them. First question, has liability been a concern with telehealth care for acute presentations? What protection is there for the provider?
So yeah, these are obviously big concerns, and I can tell you that our legal team is as much a part of our overall telehealth efforts as any other team. There's certainly risks involved. We're trying to be as upfront with our users that in acute circumstances, for sure when dealing with a patient directly, that we would not want them to use telehealth technologies if they've got a true emergency, and that they should, obviously call 911 or go to the emergency department and so on. We've got, with our community hospitals that we work collaboratively with, I think the approach has been that we're advisors to them, and that we're giving essentially peer-to-peer consultation. And that generally makes our physicians here a little bit more comfortable, knowing that they're not the direct providers of care for the patient, but simply that they're giving advice to the clinicians who have the patient directly in front of them. And finally, document. Clearly, these care delivery modalities are not really that much different than anything else that we do, and for any kind of care that we provide, we've got to document. So we urge all of our providers to document in our systems the advice and the content of the visit that they've conducted.
Do you see value in a system spending the money to develop its own telehealth infrastructure, or is the return on such an investment likely negligible?
It's very interesting because, and I will admit to still wrestling with this question a little bit myself. Many of the commercial systems that are out there now tend to be all-in-one systems where they bundle a lot of those technologies that I had in one of my later slides. They've got the video, they've got the documentation, they've got the billing, the credit card payments, you name it, it's all in there. But what's missing, I think, right now is the links to our existing EHR system. So if we're seeing a patient, for example, in a post-operative follow-up visit, the clinician who's doing that telehealth visit really needs to be able to look at that patient's EHR data to remind them about what this patient's history is. So for us, an ideal system is one that's essentially embedded within our EHR system and is seamless for the clinicians with regard to their workflow. So for us right now, in many ways, that may mean that we need to develop our own custom software, and we've begun to think about that. My hope is that over the next several years that the vendors that are offering these technologies, or frankly the major EHR vendors, will start to develop and embed these kinds of remote video kinds of visits within their core technology. Or if it's a standalone vendor, we'll be able to integrate well with the EHR systems so that we get a little bit more of an integrated workflow. But for right now, honestly, I'm still a little bit on the fence. We're sort of using standalone systems right now, but we do desire to move to a more integrated model. And clearly we're having those conversations with our vendors.
Very good. Do you worry about collecting copay or other payments at time of online service?
So I need to clarify that for right now, for all of our patient visits, we are not charging patients at all. They're either as part of a bundled payment, as I described in the postoperative care. In some instances, pilot initiatives are being grant funded, so the patients are not having to pay out of pocket. So for right now, there is no copay. But clearly, as we move forward, and especially as the payer landscape becomes a little bit clearer, we're going to need to figure out how things like co-payment occur. The thought is that, and again, this gets to my integration point of view, in an ideal world, we want to get to the point where our patient portal is the place where any patient-centric video visit will happen. And so if that's the case, we can build in the ability to pay your copay right within our patient portal prior to sort of jumping on the video encounter. But for right now, to be clear, we're not charging patients any copay.
Okay. Have you utilized wearable technology for your acute care situations such as the ED, where cart-based systems often provide inadequate visualization or are a space hindrance?
So I'm going to need a little bit of clarification. So wearable technologies, if the person asking the question could maybe type a little bit more detail on what they're after, and I'll come back to that one.
They actually wrote in Google Glass, perhaps?
I see. Okay. Yeah, we're absolutely experimenting with Google Glass. Our friends across the street at Beth Israel Deaconess have been in the press a lot with systems that they've implemented in their ED, and we're actually doing very similar pilot initiatives where we're building tools for intraoperative environments, where our surgeons can have important information about patients available to them within a Google Glass kind of environment. It's not anywhere near production yet. I don't want to misrepresent it all, but we're absolutely experimenting with that stuff. And I do think that over the course of the next several years, we'll start to see more of that emerge. Things like all of the Apple technologies, the Fitbit kind of approaches. Clearly, we're going to have all kinds of patient-centered streams of data coming our way that we need to be able to accommodate. And, we've got some initiatives already in place around our diabetes patients and being able to get at their glucometer data, but I think that's just the tip of the iceberg. We'll have a lot more of that kind of data coming our way soon.
And for those of you interested in Google Glass, we do have a webinar coming up on Google Glass in the healthcare space, so keep your eye out for that. You mentioned grant funding. Where have you been able to find support for these telehealth initiatives?
So the first is a very interesting aggregation of parties that we've got here in Massachusetts and at Boston Children's. We've got a collection of insurers that are partnering together with us at Boston Children's on coming up with innovative ways to essentially bend that curve, reduce the overall cost of care, while at the same time ensuring the utmost in patient care quality. And so one of the grants came from this organization, and they wanted us to try and pursue doing more of these hospital-to-hospital kinds of telehealth encounters so that we could prevent the children from automatically, if you will, getting shipped off to the more complex, higher cost of care facility, e.g. Boston Children's, when in many instances they might be able to be cared for just fine in the community setting. That clearly will impact our bottom line right now, but it's the right thing to do. We're getting towards a way to get at reducing that overall cost of care for that patient. And the hope is that over time, the payers and the payment methodologies will catch up to us. That's why it's interesting that it's a collaborative between us together with the payers and thinking of new ways to get at these challenges. But that's one example.
Very good. Do your physicians prescribe certain available apps from a formulary of approved apps that can go on the patient family smartphone?
We don't have an official set of apps. What I think we do, and this is variable across subspecialty, but there's certainly some areas that have a set of apps that they've found to be especially useful that those clinicians within that department will recommend to patients. And they may have flyers or a pre-printed thing that they hand to the patients to share with them. We don't yet have a whole hospital, if you will, sanctioned set of applications, though. But again, as we move forward in the future with things like our patient portal, we've just deployed a native mobile version of our patient portal. I do think that that's a great idea and one that we've thought of. So we'll probably, be addressing that over time. But for right now, it happens individually in each subspecialty with the apps that they've found to be useful for their patients.
Very good. What is your experience with patient-side technical support? For example, troubleshooting their PC or networking. Does this interfere with clinician efficiency?
So far, we haven't had that challenge so much because we've been able to have our telehealth program staff intercept those technical questions. I do think that moving forward, as these systems start to scale even further across our organization and we have more and more visits happening this way, that we're going to need to think about, having a little bit more of a robust patient-centered, family-centered technical support option available. Now, whether we would outsource that or what, I'm not sure. My real hope is that, bottom line, we make these things so mind-numbingly easy to use and foolproof that the amount of support that we'll need to provide is minimal. I recognize that that's a bit of a pipe dream, but that's the goal. For many approaches moving forward that we're thinking of, we want to make essentially iPhone and Android and iPad devices the platforms of choice for our patients, with the idea that, for most applications nowadays, if they're built well, there's not a whole heck of a lot of support that you need to provide to families to do that. So if the apps are intuitive enough and robust enough, the hope is that they wouldn't need too much assistance.
Very good. How does one identify alternatives to Skype, FaceTime that are secure?
Well, basically what I should do is have you get in touch with some of our telehealth team members. There's lots of commercial options out there. And, basically I'm not going to enumerate them simply because I think there's probably different ones that are appropriate for different settings. So on that last slide, I think the contact information is on there. Feel free to reach out, for example, to Sean Farrell. He's the director of our telehealth program. Thanks, Anthony. Yeah, his email's there. And he can point to some of the technologies that we've evaluated and the ones that we're using.
Very good. How do you coordinate scheduling? Did you build a separate system or purchase software?
Right now we're using scheduling. We're doing scheduling just within our routine scheduling infrastructure that we've always had. It is a little bit, there is a little bit of manual effort there. We need to flag what the telehealth encounters are and make sure that folks know in advance. The goal is that in the future, there'll be a little bit of a more intuitive end user experience to know as they look at their schedule, for example, that they're seeing patients 1, 2, and 3 in clinic as in-person visits, but patients 4 and 5 that they see on their schedule are remote visits, and they'll know to just log into the video system to do that. But right now we are using just our standard scheduling system as placeholders, but then with a lot of manual sort of side work, if you will, to ensure that our providers know that that visit is actually a virtual one.
Very good. Did you see an increase in your Hcap scores because of telehealth?
I don't know, to be perfectly honest. You could maybe touch base with Sean on that. A lot of this stuff is frankly too new for us to have those kinds of metrics ready at our disposal. These initiatives really are only now, they've been mature for, I'd say, about a year or so, and in pilot mode for a couple. So I think it's frankly too soon to say.
Okay. Well, you talked a lot about reimbursement and the challenges in Massachusetts. This question is, community hospitals are struggling with finances. Do you think telehealth could help them by bringing in specialists via technology and in this way finding a new revenue stream?
Yeah, I mean, for sure, as we approach community hospitals to form affiliations with them, we are absolutely pointing out our virtual technologies and the successes that we've had with existing partner organizations around there. So we've not gotten to the point yet where we're really charging for them, if you will, although that's obviously a possibility. But rather, we're using it as a feature ad for the hospital to help sort of form these partnerships with our community-based hospitals. But yes, absolutely, you could see it as being a service that you could provide. And I know that there are organizations out there that provide this type of service for a fee to other organizations that just don't have it. Actually, now that I think of it, we are providing in one instance, we are getting paid for the service from a community hospital. So yeah, I guess we're already doing it.
Okay. Do you do team consults where you get the entire multidisciplinary team together at one time, even though they may be in different places?
Absolutely. Yeah, this is something actually that we've been doing for a long time in specific domains. So 2 examples, in our cardiovascular program, we routinely have consultations with remote facilities where there's an exchange of patient information, real-time visualization of the other team members, visualization of studies, echocardiograms and the like. And actually, we've been doing that for quite a long time. We also do it, as an example, in our vascular anomalies program, where they do consultations, frankly, across the entire world, looking at specific patient cases that are challenging, and where we bring together the entire team virtually to discuss the case. So that's one that we've had a longer bit of experience with. And in fact, those kinds of experiences help to push us towards doing more in the telehealth space.
Very good. I think we're going to wind up with a couple of security-related questions.
Okay.
Did you require changes to your standard HIPAA privacy notification to patients? And the second question is, did you somehow have to assess security at the patient's side? For example, did the parent or authorized caregiver have to identify him or herself?
Oh, great questions. On the first, I don't believe that we've changed anything specific for telehealth in our notification of privacy practices. As I mentioned, our legal team has been involved from the get-go, and I can't imagine that they would have glossed over that one. And so I'm assuming that our standing policy they felt was sufficient. The second part, I just blanked on what that was.
Did you somehow have to assess security at the patient side?
On the patient side. Yeah, great question. We've not, and primarily that's because the technologies that we're providing for the patients to use, and in our initial pilot efforts, many of those technologies we provided ourselves, so we were all set. But for ones where it's essentially a bring your own device kind of model, they're web-based technologies that have encryption all the way through, and using SSL and so on. So we've not really felt the need to ensure the integrity of the patient's side of things. But I can envision as we expand over time and get to different kinds of devices as well, that issue may come up for us. But we've not attended to it so far.
Wow. What a great event. I don't think we've gotten as many questions probably in any webinar that I can recall, maybe something on meaningful use a while back, but certainly tremendous interest and an area where people are finding their way. So Dr. Nigrin, we totally appreciate you, really appreciate you coming on and doing this with us, and I think it's given folks a lot of value. We're out of time for today. As I mentioned, you'll receive an email when our archive is ready, and I think that's going to be pretty popular when that gets finished, along with the slide deck, which you can get now. For those of you who have the Chime CHCIO certification, attending gets you 1 credit. If you've asked us to communicate that, we will. If not, don't forget to contact Chime. Questions, comments, please contact me. Suggestions for improvements, and you can go ahead and view our site for our upcoming schedule. Like I mentioned, we have an event on Google Glass coming up and lots of other events and a nice robust archive. So once again, I want to thank Dr. Nigrin. Hopefully we'll get him to join us again for one of these, and everybody have a wonderful day. Thank you.
Thanks, Anthony. Bye-bye.
Bye-bye.